Good morning. This is Laszlo Kirali from Singapore. I thank the organizers, Professors Kalangos and Shetty for the invitation and for giving me the privilege to present at this important conference. This narrative review aims to examine the burden of congenital heart disease and congenital heart surgery service availability in Southeast Asia, to analyze the key factors influencing these aspects and outline potential solutions. I acknowledge Dr. Yi-Shuan Wang, a graduate at Aberdeen University, UK, for her contribution in the literature search. Congenital heart disease, CHD, has significant global burden. A population of a middle-sized European country lives with CHD worldwide. Although mortality halved since the 90s, a person with CHD dies in every 2 minutes. Especially, CHD remains number one cause of infant mortality, although its rates decrease in high and high-middle income countries. Health outcomes are closely tied to socio-demographic index that combines data on economy, education, and fertility rates. As you observe, positive trends are also visible in the region of focus of my talk, namely Southeast Asia. Asia, Europe, North and South America and Oceania exhibit higher rates ranging from 7.2 to 9.2 per thousand live births. The observed increase in CHD birth prevalence is primarily attributable to the rise in the incidence of mild defects such as ESDs, VSDs and PDEs. This trend is likely be influenced by ascertainment bias, driven by the increasing use of echocardiography and pulse oximetry for CHD screening and diagnosis. The prevalence, mortality and disability rates associated with CHD in children aged below 5 years in the ASEAN region illustrate a strong correlation with the socio-demographic index. Higher SDI correlates with higher discovery and therefore increased CHD prevalence, but decreasing mortality and disability rates. Economy, education and fertility rates expressed as SDI will equally set CHD prevalence and the financial background that a healthcare service in a given country operates. Finances influence the healthcare organization and institutional structure and the impact on the age, acuity and complexity presentation of the congenital cardiac surgical group. Therefore, SDI through financial and healthcare structure will ultimately affect the outcome and CHD survival. Complex CHD has immense economic impact, with the annual cost per patient being 4 times higher than for coronary heart disease and 8 times higher than for congestive heart failure. The highest burden is on the shoulders of parents and families of affected babies. It is worth noting that these families are typically young, would have limited financial means as they are in the beginning of their professional career, and they have limited savings, if any. To illustrate the situation, we mention an adult going for CABG. This person might have been contributing to the healthcare system or insurance for years before the surgery. In a good case scenario, he or she returns to the workforce within months and continue paying their dues. The situation is quite different for a neonate undergoing arterial switch operation for TG. Investments from the family and society await for 20 years until the survivor starts contributing back to the community and/or society. Typical factors of an increased prevalence of CHD include generally small or isolated generative population pools, lack of prenatal screening, and/or the possibility of termination for fetal anomaly, as well as consanguinity within second cousins or closer. Association of consanguinity and prevalence of congestive heart disease was demonstrated in numerous population demographic studies. Like in this one, among second-generation immigrants, CHD incidence increases linearly. That points out the role of both consanguinity and reduced generative population size, boosting bad genes. Consanguinity has strong socio-cultural roots in the MENA region and traditionally in tribal societies. However, traditions, religious beliefs, and social mobility make consanguinity somewhat less prevalent in Southeast Asia. Antenatal detection of CHD results in higher discovery rate and help better guidance of affected pregnancies, leading to fewer neonatal collapses, but also translating into a higher termination rate. The Association of Southeast Asian Nations, ASEAN, was established in 1967 and it consists of 11 countries by 2025. ASEAN aims to promote economic growth, social progress and cultural development, regional peace and stability by political and security cooperation, policy integration and development initiatives. These countries experience economic prosperity, a budding middle class, extended life expectancy. Facing the problems of an aging society, mounting healthcare costs, ASEAN started harmonizing their policies, infrastructure and fostering private healthcare sector. Cooperation offers participants a common purpose, opportunity and nurtures trust. A literature search was conducted on Medline, Embase and PubMed to identify studies on congenital heart disease and congenital heart surgery in Southeast Asia, published in the last 10 years. Table 1 outlines the key socio-demographic differences of ASEAN nations. Table 2 depicts their healthcare profiles. These tables reflect that low and middle-income countries, LMICs, tend to have larger population and poorer health outcomes due to strained resources. In the context of CHD, this means many LMICs do not have the means or infrastructure to provide advanced systems for diagnosis, treatment, and follow-up required for CHD care. There is also a perception that CHD services are resource-intensive and not beneficial to the overall population, and consequently, there is little public attention and investment interest available. This results in discrepancies between LMICs and upper middle income and or high income countries in ASEAN. Within countries, underdeveloped public healthcare systems for those facing socio-economic barriers mean further reduces and access to CHD care. There are several factors influencing the variations in CHD incidence across the ASEAN. The high birth and fertility rates in MICs versus UMICs and HICs lead to an increased incidence and prevalence of CHD, resulting in disproportionate burden of CHD. Antenatal screening required for early diagnosis and care planning for CHD neonates is often unavailable, so initiating fetal cardiac screening programs require a high financial investment that is difficult for LMICs to achieve. Countries' legal, cultural, and societal acceptance towards termination of pregnancy for fetal anomaly, TOPFA, impacts CHD incidence rates. For example, TOPFA is prohibited in the Philippines and Laos and restricted in Indonesia and Malaysia, so we can observe relatively high CHD incidence rates in these countries. Limited genetic diversity in smaller reproductive subpopulations and consanguinity practices can increase the risk of CHD. In particular, consanguinity, as mentioned, is still practiced in Indonesia as well as among Tamil and Malay population across Asia. Finally, prioritization of communicable diseases in LMIC public health policies diverts resources away from specialized CHD care services. As we have explored, LMICs tend to have higher CHD incidence and prevalence, but do not have financial means to manage this demand. This table shows the estimated congenital heart surgery demand in Southeast Asia. The incidence of CHD in ASEAN per year is based on data from IHME. The estimated CHS need per ASEAN country was determined by using a lower estimate of 2% to provide a conservative estimated number of CHD patients requiring CHS in their lifetime. This was then halved to approximate the number of neonatal young infant CHD patients who would have an immediate need for CHS. The review used reports from individual countries were available, and the European Congenital Heart Surgeons Association database for the rest. The estimated number of CHD patients with immediate need for CHS was then divided by center to approximate the number of new patients per center per year. The final 130% column accounts for the 30% increase in surgical volume for patients requiring staged operations and/or reoperations. The structure of CHS services in ASEAN are described by the availability and accessibility of CHS and funding sources. The three primary funding sources are government or employer insurance, humanitarian missions, or a combination of the first two alongside patients' out-of-pocket payment. Most ASEAN countries have a mix of government and private hospitals that provide CHD services with centralized specialist centers mainly located in urban areas. However, for rural patients, this means geographical barriers to accessing the CHS services within countries. Furthermore, patients in most countries are still expected to cover part of the cost themselves. This creates a financial burden to young families who are the main affected demographic. China, for the country's large size and population, is not the focus of this presentation. However, it's worth of a comparison with the ASEAN. China has established a tier system of hospitals with a full or limited specialist capacity regarding complexity. Expertise is centralized into few really large centers in urban coastal areas, providing referral coverage for the internal and rural areas. Regional differences are overcome by modern IT-based applications in follow-up, inter-hospital communication and education. A comparative study with the European Congenital Heart Surgeons Association database demonstrates an overrepresentation of left-sided lesions in Europe. China's centralized healthcare governance allows a lenient approach to high-risk complex cases such as hypoplastic left heart syndrome. The study also illustrates that China is quickly catching up with Europe with large-scale centers and an increasing complexity and good outcomes. A congenital cardiac service treats a circumscribed population of patients at an increased complexity level in contrast to a large number of low-complexity encounters of a general hospital. However, the specialty can benefit from sharing advanced imaging lab, blood bank, and so on services with the general hospital. The comprehensive congenital cardiac service relies on 27 availability of dedicated team equipped for all ages, complexities and acuities. When introducing neonatal and infant complex open heart surgery, the availability of ECMO and complementing catheter interventional hybrid modalities become mandatory. A three-level continuity of care is proposed that accompanies the patient's journey from either the neonatal ward or the community screening throughout the diagnostics preparation by pediatric cardiologists. The multidisciplinary team takes over for intervention at the specialist center so that after recovery the patient is followed by pediatric cardiology and returns to the community care. Absolute communication and transparency of all participants is key in established programs, but it is essential in developing ones. Traditionally, there are three ways of helping developing CHS centers in LMICs. These include charity missions, coaching programs, and establishment of local centers maintained by resident teams. First, charity missions provide short-term individual patient benefits. However, this approach sometimes regarded as surgical safari for the lack of continuity of care and follow-up on the results. Coaching programs allow for healthcare providers from one country to be trained overseas at well-established CHS centers, allowing for greater academic growth and collaboration. However, where there is a risk that assets are retained for better circumstances and leading centers treatment approaches may not be applicable locally. Possibly the optimal method for initiating a CHS program in LMICs is establishing resident teams. This approach grows out from coaching programs and it ensures that the area of need has a stable provider and cohesive multidisciplinary team that can carry out comprehensive interventions and follow-up. However, this approach is labor and cost intensive and often depends on the local institutional and or external environment. For our discussion, we will address the current barriers to equitable CHD care, the importance and methods of early diagnosis and referral, and solutions to CHS provisions in ASEAN. Barriers to equitable CHD care in ASEAN countries include demographic and epidemiological factors. High birth rate and fertility rates contribute to increased CHD prevalence, and the large rural and/or poorer populations often face financial and geographical barriers to services. Limited or even non-existing fetal cardiac screening programs mean delayed detection, inadequate disease surveillance, and may lead to an underestimation of CHD prevalence. Furthermore, limited resources have resulted in a lack of organization of CHD care, policy, research, and financing. To best utilize any developing CHS service, countries must first have well-structured, widely accessible neonatal screening programs and pediatric cardiology referral networks. Pulse oximetry is a proven, highly specific, moderately sensitive test adopted in many ASEAN countries and could help facilitate CHD detection in LMICs in a cost-effective manner. With earlier detection, diagnostic and referral networks both within countries and regionally are needed to improve access to any existing CHS service. CHS programs should meet three main goals. First, to be accessible to individuals of all ages, CHD complexity levels, and social backgrounds. Second, they should be financially affordable and sustainable. Finally, they must provide safe and high-quality services. Meeting these objectives can be challenging in the real-world context. External factors such as patient demand, the local diagnostic and referral capacity, and healthcare financing structure can affect the program's sustainability and affordability. Internal factors such as skills and professionalism of the local healthcare team, existence of local quality assurance systems, and individual organizations' policies all influence the structure and the effectiveness of CHD programs. A key solution is greater collaboration between ASEAN's LMICs and UMICs and HICs in the region. Healthcare providers in LMICs could observe and engage in training or education programs at well-established CHS centers in UMICs or HICs. Mentorship networks between these two groups of countries could bolster CHD diagnosis networks and facilitate independent CHS centers. Such collaborations would be mutually beneficial as UMICs, HICs often have reduced caseload where LMICs have large untreated population of CHD patients. Thus, partnerships between ASEAN centers would provide the required caseload to an otherwise low-volume program in HICs, preventing de-skilling and closure. The true beneficiaries would be the children living with CHD in LMICs whose lives would be changed through CHS service provisions. Congenital heart disease is a major cause of morbidity and mortality among children in Southeast Asia. The lack of prioritization of CHD and CHS services has perpetuated the neglect of patients and their families and resulted in disparities within countries and across the region. Regional collaboration is key. Leveraging on the existing cooperative framework in ASEAN and its strong cultural ties, shared traditions, often common language, similar trajectories, and mutual understanding, countries could build robust diagnostic referral networks and form mutually beneficial partnerships to improve outcomes for CHD patients in the region. Thank you for your kind attention.